Can you see the screen?
Yes.
Okay. So here comes the little big girl, Natasha Pahuja herself. She is one of the very dynamic speakers and very, proficient surgeon. She's a cornea specialist. She's working in Pune, more than 30 plus peer-reviewed publications at her age. She is one of the youngest PhD in keratorefractive surgeries, and I've had the opportunity of hearing her out at a lot of conferences, and I've never ceased to get amazed with her knowledge and her ability to communicate and connect with the audience. I guess, the environment she's been nurtured in with Dr. Pahuja and Dr. Rohit Shetty has got a lot to do. And of course, her own dynamism comes into play. And I would not even have the courage to go through all the awards and honors. And I think if I go through them, she'll probably be finishing 1/3 of her talk during that. But, the big ones are the Moscone, YKC, Pandit Award, ASCRS 216, Best Paper Refractive Surgery, APCRS 216, Best Paper Refractive again, ESCRS 216, AIOS 216, and the list goes on till 2018, WOS International Hero Award, ARVO 2018 Travel Grant Award and a paper as a hot topic of the session, and AIOS, which is the recent one, the International Hero of India again. So over to you, Dr. Natasha, and I think we are looking forward to what you have to speak on the dry eye diagnostics.
Thank you so much for that kind introduction, sir. At the outset, I would like to thank Dr. Kamal and My Healthscape for giving me this opportunity to discuss and deliberate a little bit about, to discuss and deliberate a little bit about how we are evolving with our dry eye diagnostics. So evolution here being the operative word. So no matter what is the stimulus for our evolution, we are still evolving, like managing a pandemic like COVID-19 or to a simplest thing of discovering a new tier substitute. We are constantly evolving. As I said earlier, no matter what is our stimulus for evolving, when we want to see the evolution, let's just take a step back and see our past and our history. So as Dr. Gaurav Luthra earlier mentioned, that dry eye disease was earlier just defined as the water within, and how they were treating it was as this is in Egyptian scriptures. They used to make a paste of my and lead salt. That's why they have this thick eye makeup that the Egyptians had. And I think this is where Professor Stephen Flugelfelder got his idea of nasal stimulation from. That some of the cultures, including India, used to use incense sticks to cause reflex lacrimation. So defining dry eye disease with just a three-word definition to almost calling dry eye disease as a short note now, we have come a long way in how we have evolved in understanding dry eye disease. So earlier we was just to concentrate on the diagnostics. We used to just classify dry eye disease based on Schirmer's test and TBUT as it is aqueous deficient or evaporative or maybe mixed. But understanding how multimodal the disease has become, I think the diagnostics also have to graduate from our simple Schirmer's and TBUT to a multimodal diagnostics. Now to make it very, very simple and concise, we are going to approach this in a very stepwise manner. And the stepwise manner is going to be thus. We're going to look at the history and questionnaires that are available for dry eye disease, the clinical exam, which is absolutely important, and finally coming to the investigations. Let's start with the questionnaires. Now, this has been detailed by Dr. Gaurav Luthra earlier, but what he highlighted was very important of the facial washing, how we do it. Most importantly, we have also started including this in our leading questions as to if the patients are smokers or if they are passive smokers. So if I had this a friend of mine whose husband was a smoker, and because of the passive smoking, she developed significant dry eye disease. So these are few things that need to be asked in history. Now here is a list of validated questionnaires that are available for dry eye disease. They can vary from the number of questions that you have. What is important here is that if you want to look at the quality of life that it has. Now I cannot have an OCAS or a HT analyzer at my clinic. So to understand the visual impact that dry eye disease has, I can just do a simple ocular surface disease index, which takes hardly 5 minutes to do it. But if you want to do a detailed questionnaire, which also decides of how the treatment satisfaction has been, then you can go to an Alcon IDLE questionnaire. So these are validated questionnaires that are available. As soon as the patient is done from preliminary, step 2, we give them a questionnaire depending on if I want to diagnose dry eye or if I want to prognosticate dry eye treatment. Step 2, after doing the history and questionnaires, the most important aspect here is step 3, which is the slit lamp or the clinical examination. Most often than not, most of the diagnosis is done at the slit lamp, and it makes our life so much easier just by understanding what kind of dry eye disease the patient has, as was beautifully described by Dr. S.K. Rao in his talk. But how do we objectively understand this and then take it forward to the patient? So objectively quantifying this is where the investigations come into play. Now the investigations can be either understanding the structure or the function aspect of it. So how do we classify them? To understand the function, it can be a non-invasive TBAT, as Dr. Himanshu mentioned, or it can be a tear meniscus height. The interferometry understands the functional component of the lipid layer. It quantifies the lipid layer as well as it understands the quality of lipid layer. But to understand the actual structure, which is the meibomian glands, you would have to do a meibography. So to do the TBUT, there are these available diagnostic methods. To understand or to objectively quantify interferometry, we would use a LipiView. And to look at meibography, any infrared device could do the job, be it a topographer or a keratograph. The common link in all of them that I have been using currently is the IDRA. So what IDRA does is basically it combines all of these machines into one. So let's take it step by step. So this was the user interface. What it does is it gives us the interferometry, and it gives you the video. Also, it makes it very, very simple. So it gives a tool and a colored scale which will tell what is the lipid layer thickness, and it will also say that objectively it is normal, suspicious, or abnormal. And the metrics are inbuilt into the system itself, so we don't really have to memorize the numbers. Then the next it does is the tear meniscus height. Again, it gives the same measurement, and it objectively gives a report of this that can be given to the patient little later on. After the tear meniscus height, the cone can be changed into a Placido image. So the cone, the reflection that is seen from the Placido cone basically gives us a graph, and especially areas which have got poor tear film breakup time. Now this is a non-invasive method, so you don't have to instill fluorescein into it. But what it essentially does is, based on the, as the time progresses, it gives us where the tear film is breaking up. So it also tells us localized where the problem could be. The step 2 would be actually touching the patient, which is done in meibography. So essentially what it does is it not only images the meibomian glands, it also gives a comparative score. What we can also do is manually instruct the patient, the clinical examination that we have done previously, by pressing the expression of the meibomian glands. So by squeezing, we understand how many glands were open and what was the quality of secretion that came out of it. So it also puts it into a regression analysis and gives us an objective score of what the meibomian gland is. Furthermore, they have made it a little more fancy by giving us a 3D reconstruction of the entire meibomian gland that is available in the newer software. So it makes us truly understand anatomically where the structural changes have happened in the meibomian acini. Furthermore, it can classically take very good images of what kind of blepharitis the patient has, and it is very important in prognostication. When the patient follows up after medical treatment, we can image these lid margins and truly classify as to if the treatment is working or not. So essentially, at the end of it, the step 4 gives us an absolute clear one-page report, which tells us what is the NIBUT or the lipid layer thickness, or how the meibomian glands are, what is the gland loss, percentage of gland loss, if the treatment is working or not, and the follow-up treatment can be added into it. Furthermore, objectively what we have measured, the osmolarity, can be included into the system, and it gives you a regression analysis of the entire treatment. So we have understood the structure and the function, but what we have not looked at is that how is the tear film, what is the tear film composed of? Now we cannot take all the tears to the lab immediately. So what we can do is look at the tear osmolarity. What it essentially does, this is a step 5, which will tell us that if the tear film is has increased osmolarity. Also, it can also tell us if the tear film or the ocular surface has got inflammation. Now, these are clinically available tools. Tear MMP9 costs about 1,000 to 1,200 rupees and can be done in the clinic. Also, what is important here is we don't have to absolutely look at the pink color that comes into the positive. A slight change or slight change in the hue is also important as a positive tear MMP9 treatment, positive tear MMP9 on the ocular surface. So essentially, why is it important is because in the entire key mechanism of dry eye disease mechanism, we are basically able to diagnose the hyperosmolarity and the inflammation aspect is sitting in the clinic. So after this would be the step 6, where you are actually going to touch the ocular surface so that the previous measurements are not altered. So this is the simple Schirmer's and TBUT that can be done. The TBUT is done to assess the lipid layer function. The other test that can be done is the phenol red test, which is less invasive and takes lesser time than the Schirmer's test. And of course, once we have stained the ocular surface, it would be vital to look at the staining technique. Again, what is an advantage with the IDRA is that it gives you a corneal color which is correlating with the corneal staining. So we can have a reference image and then we can add it into the reference into the system and give us a final output of where do we stand in classifying the patient's dry eye disease. So having said that, these are patients where we have most of our patients who have classical dry eye disease will be qualified and will be treated accordingly. What is important here is the patients who are symptomatic but have no signs. So these are the patients who come with these typical complaints that, my eyes are tired, my eyes are hurting after cataract surgery, as has been discussed earlier also. So these are the patients who have these unexplainable pain, and we know that there is the effect is the pain, but the cause behind it, what we have understood till now, is that there is inflammation. So when we looked at inflammation, you just type inflammation and vitamin D and you get more than 460 papers on inflammation and eye and vitamin D. And what is very important here is that we have understood the role of vitamin D in the immune system of the ocular surface, as well as in the systemic immunity. And what is even further important is that we have proved it and validated that vitamin D is important. And following Professor Rohit Shetty's talk, he made my job so much easier because he's highlighted the role of dry eye and dendritic cells that are present on the ocular surface. What it also does is it causes changes in the nerves of the eye. And how do we measure? This is the step 7, where we can actually measure and quantify different layers, which is done by the in vivo confocal microscopy. The important one here is the subbasal nerve plexus. So combining all of these, we are able to take it step forward. Now, this would be a luxury, and it is an important research tool where we can collect the tears that we have done from Schirmer's and collect the serum. And a combination of all of this, if we can send it to the lab, we will have a more insight of understanding the dry eye disease, which may help us give better treatment to our patients. But clinically, what is currently available is these are various studies that have combined what are the emerging diagnostic technologies for dry eye disease. I have put up a chart here which basically tells us which layer of tear film are we looking at and what is the best way to evaluate that layer of tear film. Now, why is it so important? Is simply because our treatment depends on what we are diagnosing and how we are diagnosing. So depending on which layer of the tear film is involved, we go ahead and treat that layer of the tear film. Just a passing remark on why diagnostics are important, just not in a cross section as diagnosis, but also the follow-up as a treatment. Now, this was a patient, this was actually my brother who was undergoing the IPL treatment. So he had a significant amount of dry eye. What was very important here is that I did a pre-IPL for him. The meibomian glands looked absolutely disturbed. But if you look at the pre-IPL, he had, I cannot explain this, but he had a lot of meibomian gland dropout. But post-IPL, after 3 months, he had regeneration of, if I can really classify it that way, he had regeneration of meibomian glands, which I have not seen so far. I've not even heard of so far. But this was like absolute miracle. Fortunately, he was my brother, so he was very happy, and he sent me 4 more patients after that. And I was very, very fortunate to contribute into the atlas that was published by SPM and IDRA. It was a clinical atlas. So it just increased my interest into diagnosis of dry eye disease, and the entire process has helped me understand and given better insight into what dry eye disease is. To sum up, it is very simple. It just looks like it just looks too much and too messy and too much to grasp, but it's very simple. Step 1, take a detailed history. Step 2, give a questionnaire to the patient, depending on which questionnaire you're comfortable with. Step 3, do a simple slit lamp examination, and this has to be in this order so that it is non-invasive and we're not disturbing the ocular surface. Step 4 is the non-invasive methods that we have described already. Step 5, touch the ocular surface, look at the tear film composition in terms of osmolarity or MP9. Step 6 is the clinical test during which you would instill fluorescein stain or lissamine green stain, the vital dyes, to improve our diagnostics, and which we are actually more comfortable with as clinicians. So this just validates what we have done in step 4, which is the non-invasive methods. Step 5, if none of these are working, it would be vital to look at the systemic workup of these patients, because there could be something more which is just not apparent on the ocular surface, or as we call it as the white inflammation or subclinical inflammation. And if you have the luxury, you would go to step 8, which is the advanced diagnostics of looking at tear biomarkers or systemic biomarkers, also looking at the confocal imaging or OCAS. I would like to conclude this by thanking my mentor, Professor Rohit Shetty, who has just induced too much curiosity, which has helped ask too many questions. And I'm sure Dad and Professor Shetty get the brunt of it by asking silly questions. But thank you for making me more able. Thank you very much.
By the time we are over, I think it's an amazing presentation, very lucid, and you practically, I think, summed up everything. There's